we have to keep in mind that the way FOLFIRINOX is being used is not the same as was published.
Right.
Right. Right. So what are your modifications? Everybody modifies FOLFIRINOX that I know.
Well, I personally dropped the bolus 5-FU. In fact, the trial we have, SWOG, is the same. We dropped the bolus 5-FU, assuming that the treatment is not affected. But I also know that other people do different things. So,
Caio?
So it's, you know, we all do drug development here. And, you know, most of the time when we combine agents, we tend to drop the doses, predominantly in cytotoxic drugs. Now we have in pancreatic cancer 2 regimens that use full doses of all drugs. FOLFIRINOX at 85 oxaliplatin, 180 irinotecan, 2,400 infusion of 5-FU in 400 milligrams per meter square of full doses. Gemcitabine at 1,000 weekly times 3 every 4 weeks with nab-paclitaxel in 125 also, you know, 3 out of 4 weeks. So you have 2 regimens with full doses. So it's very tempting to do a modification. Yeah. There are modifications both in the FOLFIRINOX regimen as well as in the nab-paclitaxel gemcitabine. But this is always, in my opinion, dread with hazard, because we are not based this modification in phase 3 trials. We're based in that modification in experience in I believe this is as good at. Yeah. So I try to shy away from it. I try to modify the doses after starting rather than, you know, start low and escalate.
Okay, so you use the full doses of both?
Whenever I use them, I start them at full doses.
Tom?
I'm not so brave. You know, I definitely drop the bolus and even take a dose level reduction of the irinotecan to 150. You know, it's the institutional practice that I think most of my colleagues are doing the same thing, and we've written protocols that have piggybacked on that dose regimen, and I think it is more tolerable. Obviously, you're right, we don't have the phase 3 data to decide whether it's really as effective, but just as clinical trials tend not to have the same real-world toxicities as we see in the clinic, I think we have to account for that and try to dose reduce them just a tad so that we can at least get them through a few cycles and assess the response. But I agree with your rationale. I understand it. I just I've found it very difficult to give full dose FOLFIRINOX and full dose nab-paclitaxel for that matter. Patients, I do start them off on full dose, but I tend to have modifications very quickly. It is not that easy a regimen to get through either.
Do you check the UGT1A1 before you do that?
Never.
Never. Anyone here does?
No.
I do.
You do?
Yeah. Well, I mean, with experience, I've seen that if you have the Gilbert syndrome and give them the full dose of irinotecan, I've seen toxicity for sure. Although it's not very consistent to say that every single patient will get all toxicity. Yeah. But if I can really predict how the patient is going to respond in terms of toxicity, I would like to do that.
Yeah.
Can I just make one?
Sure.
We actually have that as part of the panel. I'm not going to disclose the third party that does our panel, but it's actually, there is a pharmacogenomic component in the panel. It's a next gene sequence. We actually get the gene. But, you know, the patient, for rules, Medicare rules, have to be at least 2 weeks after they're discharged from the hospital for us to be able to solicit the test. So by the time the test gets back, I'm already starting the treatment. Yeah. So I actually am analyzing that actually as a predictor, but it's too late when I start the treatment. So,
George, do you like the boluses? Do you keep the boluses?
I do. I like boluses. I'm a little bolder. Yeah.
Wow.
Because you know, the reality is we don't know how these drugs interact. We know there's an interaction between oxali and irinotecan. We know there's an interaction between 5-FU and oxali. Remember, oxali almost got kicked out because by itself it didn't do anything. So we don't know what the real interactions are. And there's this famous story, I was with Degremont on a bus, and I asked him, what is it? Is it the bolus? Is it the continuous infusion? He says to me, I don't know. And he's the father of that regimen. So, yeah, he's like, George, I don't know. So that's my best French accent. So I take the irinotecan down by about 20%, and I take the bolus down by about 20%, but I don't throw it out. And you're right, Gemabraxine, you do have to make dose modifications. Remember, it's a higher dose, 125. milligram per meter squared, not the lung dose, but I might push that dose and try to lower my gem like we did in the old days. So
let's throw in the use of Neupogen. Do you do it with FOLFIRINOX?
Not prophylactically, no. I let the patient's bone marrow express itself and then move from there. And that's, we also talk about this is another factor. What are the costs of the different regimens? Everybody says, well, Abraxane's expensive, but once you start factoring in Neulasta into FOLFIRINOX, it does get expensive. And then when you factor in hospitalization, that also gets expensive. So that's another factor that I think we have to pay more and more attention to.
And Philip, things that folks don't talk about as much as modifying the gem-nab up front, right? And thinking about the use of growth factors there. I mean, certainly the original IMPACT study had folks using Neupogen for a few days here, a few days there. And can we make the regimen modified to be kinder to our patients? What data have we seen there?
My good friend Tony Saab does it, and that's my evidence. We don't have really any good evidence to support either how to modify or to see the results of the modification in terms of the efficacy, and that type of data will never come. I personally do those modifications for the nab-paclitaxel and the gemcitabine combination, and I do that mostly in the older patients. And also in patients who are younger, who are going on the treatment for months and months, because then they start to have side effects that even if you use G-CSF, you're not going to overcome that. Fatigue, neuropathy, the malaise which goes with the treatment. So, but sometimes in older patients with performance status like borderline, I would start with every other week. Yeah. And every other week is my preferred. And in fact, I can tell you my personal experience has shown that every other week really makes patients feel better after experiencing a lot of the side effects of the fatigue. And so I think starting off right away with every other week, I will not do in an average patient. And in the minority of the patients who I think that they're not going to tolerate it, I do it every other week. But in patients who are continuing for a while, then that's something I will do.
Yeah, I agree. I mean, I think it's nice to have gem nab-paclitaxel, at least some data supporting an every 2-week dose regimen, because it is so much easier on patients, and it is a really nice way to dose it. And the fact that even in a single-arm sort of setting, that it seems safe and reasonably effective, that's nice, because it is a very good way to dose modify that regimen. Yeah.
All right, I got to disagree. I still give it weekly. I shorten the cycle day 1, day 8, every 21 if I'm worried about that. But every 2 weeks, we talk about modifying FOLFIRINOX. We don't know the outcome. We don't know the outcome when we do it every 2 weeks. That's a single institution study, so I think you got to stay close to how that protocol was. So
I agree with George.
Thank you.
So we're divided here, 2 against 2.
See, I love it. I love it. Controversy. Should I be the deal breaker?
Exactly right.
Yeah, I'm political too. So let's talk about, though, we have these patients with pancreas cancer. They are in this inflammatory state. They're anorexic. They're in pain. They feel poorly. And certainly people have used different methods to associate what's clinical benefit response, what's a response rate, how do we really tell or assess response in a pancreatic cancer patient? George?
I'm old-fashioned. I still scan the patients, just CTs every 2 months, monitor the tumor markers, don't make treatment decisions based on that, but I do monitor them. And obviously, if the patient's miserable, we're not going to keep treating them, so we do institute breaks and try to provide as much support as possible. And Philip said that earlier. We really have got to manage these patients. I think people forget that pancreas cancer is not breast cancer, it's not colon cancer. You really have got to manage the patients and stay on top of their pain, their nutrition, their diabetes, their blood clot risks, their bile duct function, all those important aspects of pancreas cancer, and that's why all you guys are experts. So.
And certainly with the responses that we see with some of these new regimens, what's really nice that goes along with it is the patients start feeling so much better, and that's the big thing, right? Is that why are we doing all this chemo that has all this toxicity? It's to make the patients feel better.
Underappreciated pain control, and I think even our radiation colleagues help with the pain control. Yeah. So sometimes they can get in there and radiate the primary and help us out. So, and our gastroenterologists obviously with endoscopic guided neurolysis of the celiac plexus. So yeah. Absolutely.